Now that everybody's ready, um, before we start and what we want to talk about, what we're going to discuss about today, I was just flipping through a couple of books um, about what about on a crash course for Malaysian doctors for housemanship in preparation for housemanship. Let me show you the book. I don't know if Ivy has this book or something. But I've had this book for over 4 or 5 years now. I don't really talk about this book, especially to non-Malaysians, because the forms, everything, it's very Malaysian specific, specific for the ecosystem, the healthcare system in Malaysia. But there's this one book too, and it's sort of like a guideline as to what you need to prepare for housemanship, what kind of books you need to get, what kind of topics you need to study before housemanship and stuff like that. The things you need to know before housemanship, abbreviations, because we have a lot of abbreviations that we need to know. And well, basically a short um, a short guideline as to what you need, what an average Malaysian medical graduate will need to prepare before being drafted into housemanship. And I usually just see the front page. I don't, I did not realize that there's actually something at the back here. And I just realized today that something was written at the back, and I felt that it was what's written at the back is really it woke me up kind of, and I thought of starting the class with reading this. I hope that's okay. Okay, so what's written here at the back? It says here, excellent housemanship oath. Excellent housemanship, excellent houseman oath. Houseman is an intern. Um, okay, so it says here, I am an excellent houseman. I am keen to learn and ask questions. I practice and improve my clinical skills every day. I enjoy teamwork and networking. I am fully responsible of my patients. Their needs come before mine. Strong, yeah? Their needs come before mine. I choose to be happy every day. I determine my own self-esteem. I am immune to harsh words and bad perceptions. I choose to be an optimist. I seek the positive side of everyone and everything. I renew my intention of being a virtuous doctor every day. I enjoy adding value to others because God will add mine. I just felt that it was very sobering, and yeah, just thought of reading it out loud to everybody. I don't know if
Thank you.
you're welcome. I hope that it woke me up so much today. I was like, oh, okay, interesting. And I felt that um maybe it's just the graduating syndrome and all that. And I've been thinking of my work life and stuff like that, and reading that just felt like something new is coming up. But anyway, today, we're going to continue to talk about um, stuff, about CVS stuff. And we talked, what was it last week? We talked last week, yeah, about how to treat, for the past 2 weeks, we talked about how to treat and diagnose ACS. And we covered a lot of drugs, CVS drugs. And I'm sure most of us have already um, heard of all the CVS drugs, and to some extent, we are quite familiar with the drugs. But the problem with that, again, is that a lot of us, we just know the drugs by name, and whenever treatment comes in, whenever someone asks us about treatment, we just have a tendency to just throw everything in. Hopefully you will hit something, but that's in reality, that's not it. In actual hospital situations, and it says my internet is unstable. Can everybody hear me clearly? Am I cracking?
Yes, we can hear you.
Okay. All right. Um, in real hospital setting, everything follows an algorithm, and it means there are first line of drugs and second line of drugs, there are third line of drugs, and there are even drugs even within the spheres of within the spheres of CVS drugs. Some of them are even contraindicated. So um, that is why I want to first talk about the table that I sent everybody. Let me open it. It really depends on you how you want to do it, but I think it's important. We have we talked about differential diagnosis, right? And how to come up with differential diagnosis. I don't know if there's such thing as differential treatment, um, but I just thought it's important to differentiate how each of these big CVS diagnosis um, are treated. And some of the first line are not the same as the other first line, second line, and third line, and so on and so forth. So it really depends on how detailed you want to write. You can write just the group pharmacological group. Maybe you can write for example, CCS, number one, beta blockers, number two, and stuff like that. But then again, if you want to go a little bit deeper, some beta blockers are contraindicated, or some even contraindicated. That, for example, in CCS, remember in CCS there are in chronic coronary syndrome there are 6 types, right? We talked about that: classical, stable angina, new onset, stable angina, history of ACS for less than 1 year, and the six points that we talked about, including your Prinzmetal vasospastic angina, also falls under CCS. And in Prinzmetal angina, your beta blockers are contraindicated, right? Your beta blockers are contraindicated because they can induce vasospasm, and vasospasm is the cause of Prinzmetal angina. Yeah. So that is why I divided it into first line, second line, third line. If you would like to subdivide them, for example, in CCS, there are 6 types of CCS, right? 6 different ways or different forms or phenotypes of CCS. You can create your own table and differentiate what is first, second, third line, and what is contraindicated. Or, well, I'm just gonna leave it up to you how to fill the tables, but as long as you know which one is first, second, and third, and why they are first, second, and third, and what are the contraindication. Your contraindication can be, depends on you too, whether you want to write like the name of drugs or scenarios. For example, like what I said just now, CCS, your contraindication number 1, your first point, you can write there, Prinzmetal angina, beta blockers are contraindicated. So what do you use? You use calcium channel blockers, something like that. I understand we've already talked about ACS and CCS a little already, so we're not going to go through them again. So I would encourage you to go back and go through the notes again, the materials that we've talked about, and trying to fill the table as to which one is first, second, and third, and contraindicated. If you have any questions or you are not really clear whether some drugs are first line or second line or third line, just drop the question in the group chat and we'll talk about it. Okay. The reason why I think this is important is because it's good to know. If you notice some guidelines, that guidelines that we follow, whether European, whether American and stuff, and even our own guidelines in our own country, as much as there are some disparities or some little differences, there are some drugs or some rules that are universal for all. So writing this down helps us to understand what are the rules, or what are the drugs that we certainly can use, or we are certain that they are first line, we are certain that they are second, we are certain that they are third. And also, as we read more on guidelines, especially if you want to sit for board exams of different countries, for example, American or the UK board exam, or even Australian or Canadian, as you study for these exams, you might notice some differences. And as you compare different guidelines or different information from different countries or different board exams, you will also, from this table, you will also understand which points or which rules fall under the gray area. What I mean by gray area is because some countries, they have different different way of prioritizing things. Let's put it that way. So understanding this also helps us to understand comparisons as well. So yeah, that's that. Any questions so far about this table? No? Okay. Okay. So as you see our table, what's left there is hypertension and heart failure, yeah? All right, so the homework that I sent to everybody, first point is classifications, right, of all of this. We're not going to go through, like I said, this in the text. We're not going to go through all the classifications because I think they are pretty straightforward, and you can find them in your lecture notes and stuff like that. But nevertheless, we will just go through them to make sure that everybody is still on the same page. Like not in depth, but just as to what. Yeah. I can't hear you.
Okay. Can you hear me now?
Not very clearly.
Okay. Sorry. Anyways, for the classification, I did not see classification for CCS, and I don't have lecture materials on that.
Okay. CCS. Maybe everybody, I don't remember who came for the class for CCS. So let me repeat the classification for CCS again. Number 1, classic stable angina. They are divided into 6 phenotypes. Okay, CCS is it's divided into 6 phenotypes. First is classic stable angina. Second is new onset of congestive heart failure or left ventricular dysfunction. New onset of congestive heart failure and left ventricular dysfunction. Third phenotype
congestive
is
of chronic.
new onset of congestive.
Oh, okay.
New onset it's weird for it to be chronic.
All right. I thought it. Yeah, never mind.
Okay. Third is history of ACS for less than 1 year. Fourth is history of ACS for more than 1 year. Fifth is your Prince metal. vasospastic or microvascular angina. They are synonymous. And 6, asymptomatic angina with ischemic changes on ECG.
Cyst is what?
Asymptomatic.
Okay.
It is with ischemic
With
changes.
what?
Ischemic changes on ECG. The term CCS is not very much well known because it's very recent. It is very recent. I think they coined it, was it last year or 2 years ago? Not more than 2 years ago. So you might not see this in lectures, in lecture material. I did not see this in lecture material when I was in third year or fourth year. Okay.
They are part of therapy fourth year now.
They're part of their
therapy. Yeah,
oh, that's good.
fourth year
Okay.
now.
Okay, that's good. Now that they are updated. That's good. Okay. Can we move on? Nifia, you got everything?
Yes, thank you.
Okay. All right. Let's start with hypertension. A very common disease, common CVS disease. Ooh. Okay. So when we put diagnosis of hypertension, it consists of several things. All right. So as we know, hypertension is divided into your essential hypertension or secondary hypertension. Yeah, that's the common one. So your first part of your diagnosis is essential or secondary. Choose one. Then here in Russia, they apparently have a difference. They apparently made separated stage and degree, but in European and American guidelines, they don't separate it into this what stage. It's different. So in Russia, stage here is not the degree of from the BP level. When they talk about stage, is the degree of end organ damage. First stage is asymptomatic without any organ damage. Second, with one organ damage. Third is 2 or more organ damage. That's the Russian classification. We're not going to. I don't think I don't. Maybe some of us might practice in Russia, but if you're not practicing in Russia, this does not apply. Degree of hypertension. I want to show you something. Where is it? Okay. Okay, this is the European guideline for hypertension. You see, this is what we use. Yeah, here. This is what we use: optimum, normal, high normal, up till 180 over 110, third grade. And hypertensive crisis is above 180 and above 180 and 120. That's hypertensive crisis. Then isolated systolic hypertension, and yeah, that's that. Now I want to draw your attention. Can you see this too? Okay. Between the American and European classification. Maybe you've heard this already, maybe you've not. Well, I'm just gonna go through it again. On your right, this side is European. On your left is American. You see your hypertension here. For European, hypertension begins. The definition of hypertension is above. What happened? The definition of eh, okay. The definition of hypertension is above 140 and 90, while in American Heart Association or your American Cardiac Association, it's above 130/80. You see that in American classification, the threshold is lowered. So as that lowered, everything else changes. Your normal is less than 120/80, and as and anything above 120, even 120 to 129, is already considered pre-hypertension in American Heart Association. While in European, 120 to 129 is still considered normal, and 130 to 139 is only considered high normal, not even pre-hypertension. But your in American Heart Association, 120 to 129 is already pre-hypertension. So as this gets lowered, the first grade, second grade, also the guideline, the degree has also been changed. So that's that. Right. So talking about hypertension, it's not just an increase in blood pressure for a period of time, And by the way, just because a diagnosis of hypertension cannot be made if there is no constant reading of hypertension, of increase of elevated BP. If your elevated BP is only for it's transient, it's not considered hypertension. If you are running, or if you have anxiety and stuff like that, your BP is expected to increase. That does not mean that you have hypertension. So if the changes are transient, you can't put your hypertension diagnosis. Anyway, understanding that hypertension is a chronic process, it means that some organs will be damaged, right? And they call this as hypertension mediated end organ damage. So what organs are damaged here? First would be your heart, of course. So in your heart, what you'll see your left ventricular failure, or left ventricular filling defects, or and in the end you'll get your left ventricular hypertrophy. That's the heart. In blood vessels, in coronary artery, you'll see plaques, atherosclerotic plaque. There'll be your intimal damage. So when your tunica intima gets damaged, you know what that means already, right? We've talked about Volkoff's triad a lot of times already, and as the endothelium gets damaged, that is already a call for thrombosis. So as plaques gets formed on the endothelial layer of the vessel, your thrombus can also be formed, can also get stuck there, and this will increase your risk for your MI and any transient ischemic attack of the brain, stroke. So that's just the coronary artery. In large arteries, you'll see that the arteries are stiff because it wants to compensate, with the increased pressure. So large arteries are found to be stiff, and then there is some difference in your your BP on upper and lower extremities. So your ankle brachial index will be different too. Kidney hypertension is one of the predisposing factor for your CKD, your chronic kidney disease. You see increase of creatinine. You see that your glomerular filtration rate will decrease. So that means that there's signs for for kidney failure. And you know, right, kidney failure can be divided into different stages based on your glomerular filtration rate. That's that. And next will be the presence of albumin in your urine. So albuminuria, right? Next system will be the eye, and they call this hypertensive retinopathy. It is more prominent in hypertensive crisis, but yeah, it can still happen in prolonged uncontrolled hypertension. And you see retinal hemorrhages, you see microaneurysm, dilation of the vessels, you see exudation, hard exudates on the retina, and these so-called cotton wool spots on the eye, and papilla edema. Papilla edema. If you open some, I don't remember where I saw it before. I was in Dimitri's lecture, but anyway, there are different degrees for hypertensive retinopathy.
Dimitri's lecture.
Yeah, Dimitri's lecture. Hypertensive retinopathies, there are different degrees based on what you see and stuff like that. So you can write that down. So you can note that down. You can write it. You can go ahead and read up on that, on how to grade your hypertensive retinopathy. Next organ is your brain. As I've talked earlier, it increases risk for your transient ischemic attack, increases risk for stroke, infarcts, and bleeding, your hemorrhages, whether it's subdural and stuff like that. They're basically any forms of intracranial hemorrhage. Okay, so those are your heart, your blood vessel, your kidney, your eye, and your brain. These 5 organs, this so-called hypertension mediated end organ damage. Okay, all right, now that's that. Let's now talk about treatment of hypertension. Treatment of hypertension. All right, when we talk about treatment of hypertension, our target BP when we treat hypertension is 140 and lower. 140 and lower. Of course, if the patient is probably first grade, maybe first or second grade, depending on which classification you're using, whether American or European, of course it would be best for it to be less than 120/80. Okay, that's the optimum target for management of BP. So yeah, to treat hypertension, it can be divided into your monotherapy or combined therapy, depending on oh, before I forget, besides your stage and degree, you need to put in your risk group as well. Risk group. There are 4 risk groups, and depending on what's involved, whether the patient has diabetes or maybe the patient whether the patient has diabetes or the patient has other history, whether has history of stroke and stuff like that. It depends. That falls under, let me show you if I board. This is the risk factor: low, moderate, high, and very high. We learned that low risk here in KSMU is first group, moderate second group, high risk is third group, and very high risk is fourth group. And from here, we can know which one, which group, which stage of hypertension it falls under. Stage 1, 2, or 3 here, based on the risk and your BP level. Okay, so treatment is based on this, whether based on your BP levels and your risk. And this is one rule that you can write down. One antihypertensive drug can reduce 20 millimeter mercury, systolic millimeter mercury, not just systolic, sorry, can reduce 20 millimeter mercury. One. So what does this mean? If the patient comes to you with, let's say a BP of 140 over 90, that does not mean that you give one drug, it will reduce to 20. We need to understand that we need to ask the patient what is the usual BP, if the patient knows the usual BP. If we understand that the initial BP is increased by 20, that means that one antihypertensive drug can reduce that 20 millimeter mercury. So your hypertensive attack will need to still rely on your initial BP. If, let's say, your patient comes in with 160 with a hypertensive attack of 160, but his usual initial BP is 100 and let's say 140. You want to reduce it to 120, yeah? So that already means that you need combined therapy. You need more than one drug already, because you want your target is less than 120/80, right? That's 120. So you need already to give two or combined therapy for to treat the patient. So when do we know that we want to give monotherapy or combined therapy? Is based on this. If patient is based on what I just said just now, right? Based on the maths that I told you earlier on. But if a patient comes in, let's say, with a newly diagnosed hypertension, then you can try with monotherapy first. Also, the next criteria we need to check will be the age of the patient. If the patient is less than 55 years old, we can start with monotherapy and check for the effectiveness of the monotherapy. If it does not work, then we need to monitor BP and find the pattern of the BP and calculate from there if it's okay to just maintain monotherapy to reduce the BP by 20, or we need to up titrate the drug or to add another drug. But anyway, any high risk patient, group 3 and 4, we need to give combined therapy. And these different drugs, they have different purposes and they protect different organs. And monotherapy is, like I said just now, right? It's given to patients that are newly diagnosed, or patients that are very old already, old as in more than 80 years old, or frail patients, and or patients that they cannot tolerate hypertension therapy. or patient that is very susceptible for hypotension, like you give just one drug and the BP will just drop very quickly. So if that's the case, then monotherapy would be the way to go. So regardless of monotherapy or combined therapy, I hope everybody understands when to give one drug or double drug or more than two drugs. So regardless of that, our first line of drug that we use for hypertension are your ACE inhibitors and your calcium channel blockers. ACE inhibitors and calcium channel blockers. These are your first line. Now, we need to understand the ACE inhibitors. They fall under renin-angiotensin receptor, renin-angiotensin system blockers. They are called the RAS blockers, right? And under this group of drugs, it consists of two: ACE inhibitors and your ARB, your angiotensin receptor blockers. So if you choose your ACE inhibitors, you don't give ARBs anymore. You don't give both together because they both work in the same system, and it's redundant to give both. So choose one. Generally speaking, ACE inhibitors are better, are more effective, and they are nephroprotective. They are more nephroprotective than ARB, generally speaking. So your ACE, if you were to be given a chance, if you are given a chance to choose between ARB or ACE inhibitors for effectiveness sake, ACE inhibitors would be preferable. But if the patient, the problem about ACE inhibitors is that ARBs are better tolerated than ACE inhibitors. So patients tolerate ARBs better than ACE inhibitors, and the most common side effects of ACE inhibitor is dry cough and edema, and pedal edema. The reason why dry cough is one of the side effect is because it affects the kinin kallikrein system, your bradykinin. That is why the homework that I gave everybody is to be familiar with the renin-angiotensin aldosterone system and your kinin kallikrein system together with your arachidonic acid pathway, divided into your cyclooxygenase and lipooxygenase pathways. These are these are important pathways that everybody need to know. So you can, in monotherapy for hypertension, you can start with your ACE inhibitors or your calcium channel blockers. Any calcium channel blockers would do. But if you would like to start with combined therapy, which occurs very, very often, you can give, it's usually in the same pill. They call it double single pill combination. Your ACE inhibitors plus your CCB, or ARB plus CCB. They are very common. They are targeted for the heart, targeted for the kidney, targeted for the vessel and the brain. They protect all of these systems. That is why they are very good drugs. So if your calcium channel blockers are poorly tolerated, your CCBs are poorly tolerated, you can, another alternative is ACE inhibitors plus diuretics, or ARB plus diuretics. Remember, your ACE inhibitors and your ARB never together. So everybody understand the alternative, right? Your ARB, one side, your ACE inhibitors and ARB, and the other combined with either calcium channel blockers or diuretics. That's your first step to treat hypertension for combined therapy. First step, that's the first step. So if it is not effective, then we need to progress to second step. Second step is to use triple therapy. The first step was double therapy, right? And the third step is triple therapy. 3 drugs combined under one pill. As you can guess it includes your renin-angiotensin system blockers, your CCB, and your diuretics together, like how we understood before. 3. Your diuretics, preferably using your loop diuretics, which includes your furosemide and torsemide. So that's second step. If that is not effective, you need to do quadruple therapy. Quadruple therapy, what does this mean? It does not mean that you give, like, they combine 4 drugs into one pill. Well, I hope that they created something like that. But it's using your triple therapy drug, that one pill, triple therapy, plus one extra tablet. We are giving the patient 2 tablets because it's impossible to give 4 tablets, and it's not effective to give a lot of pills for patient. It's better to give one single pill. So your triple therapy pill, 1, and your second tablet, 1 extra second tablet. Now, what is that second tablet? It's either your potassium sparing diuretic, which is your spironolactone, or your beta blockers. Now, from this we understand that beta blockers, where is it located? It falls under step 3, right? So it means that it is third line of drug. The reason why I want to highlight this is because previously beta blockers are considered first line. Previous guidelines. Previously they are considered first lines. But now it's no longer first line. In fact, it was even excluded from the main drug treatment for hypertension. Why? Because beta blockers, they found out that it is less likely for it to prevent any future stroke attack or stroke attacks, basically, and it has a potential to impair. There's a potential impairment of glucose tolerance, and there was a study that proved that patient with diabetes mellitus, there is an increase of insulin resistance just from the use of beta blockers, and it impairs the secretion of insulin in the body just from beta blockers. I'll talk about that a little bit later, but I just want to draw your attention and to point out that beta blockers are not your first line. They are your third line, and they are used only when necessary. Okay, now that's step 3, right? So step 4. You think there are only 3 lines? Step 4. If all of your drugs don't work, it means that you need to start consider secondary hypertension. Your secondary hypertension, there are many causes of that secondary hypertension, secondary causes of hypertension in different systems. Your endocrine system, you have your in this, for example, endocrine system, your hypothyroidism, your Cushing's disease, your hyperaldosteronism and stuff like, and so many others in endocrine system. Diabetes sometimes can also cause secondary hypertension. Your any kidney disease can cause can cause hypertension, be it glomerulonephritis, your polycystic kidney disease, your CKD and stuff like that. Or any kidney disease can cause secondary hypertension. So if all your treatment don't work, or your treatment plans don't work, then you need to, your fourth step is to consider secondary hypertension. Now, with all of these things that I've talked earlier on, one thing that we need to bear in mind is that they are given based on an assumption that there is no contraindication. We need to bear in mind that we can't just give drugs because they are in the algorithm. We need to also consider if the patient has any contraindications, and we'll talk about that a little bit later. So, any questions so far before we move on? No? Clear, yeah? Step by
I
step.
have a question.
Yeah.
I read in one of the literature saying a two-drug combination of ACEI, ARB, and beta blocker are not helpful and should be avoided.
All right.
Meaning we have to add a CCB instead.
Correct. Remember, you don't give your ACE inhibitors and ARB together. They are never given together. They should not be given together. They should not be given together. And beta blockers, like I pointed out earlier on, is no longer proven to be effective anymore. So it's better to choose one of your ACE inhibitors or your ARB, choose one, plus CCB or plus diuretic, if you want to combine two. If you want to combine three, ACE inhibitor, CCB, and diuretic, or ARB, CCB, diuretic.
All right.
Okay. All right. No more other questions? Okay. There is a new drug. There's actually a new drug that they are still studying. It's not in the guidelines yet, but while I was reading MRCP material, they talked about a drug that is called direct renin inhibitor. We have ACE inhibitors, right? That inhibits the angiotensin convertase enzyme, right? And angiotensin convertase enzyme. But this drug, it inhibits renin itself. And you know that renin, if you remember, or if you can go and check the pathway, renin is used to convert your angiotensinogen into angiotensin 1. So this drug is called aliskiren, ALISKIREN, aliskiren. Maybe it will be added into the guidelines in the future. I don't know. Maybe we'll see.
Please, can you spell it again?
Let me type that out in the chat. ALISKIREN. Aliskiren. They are called direct renin inhibitors. Okay. Now, as maybe when you were in third year, or for Nife's case, when you are in third year, when you study antihypertensive drugs, you might have heard other names of drugs too, other cardiovascular drugs used in hypertension, which I'm going to talk about right now too, and which I'm going to explain when we use them. We don't use them in our normal day-to-day correction of hypertension. So One of them, they are called central acting antihypertensive drugs. One of them is methyl dopa. Methyl dopa. It is used in pregnancy. I'm going to talk about hypertension and pregnancy later on, a little bit later. But methyl dopa is one of them. Next is moxonidine. Moxonidine. Nidine. This drug is considered third line. Third line. They are used when all your conventional drugs fail. When all of them they don't work and all that, this is your third line. So see, this drug is not very commonly heard, right? And remember,
can you spell it again?
I wrote it in the chat. Moxoni. Oh, sorry. I put it.
Chat.
It's sorry. I sent it to IV instead. Alice Kirin was the drug just now, and moxonidine. Moxonidine. Not a very commonly heard drug, right? I remember just now I said that beta blockers are already considered third drugs. So you see, your beta blockers are even the same level as this unknown drug. But anyway, this is another drug that we can use. Next is clonidine. Clonidine. You might have heard this before. It's not a very it's not an uncommon drug. It's kind of common to use it. They are alpha receptors stimulator, and it stimulates the alpha 2 receptors in your vasomotor centers. So they are kind of sympathomimetic. Okay, so these are some drugs that are out of the normal ones. Okay, next thing I want to talk about is hypertension and diabetes mellitus. Understand that diabetes mellitus is also a very common endocrine drug and endocrine disease.
Can I ask a question?
Yeah.
Okay, they said no ACEI as a monotherapy in an African population. What to give instead of ACEI?
Sorry, what?
They are saying no ACEI as a monotherapy in African population. What to give instead of ACI among the Blacks nations?
Okay. Let me show you. Where was it? The heck? Plus Give me a sec. Let me show you something. This was actually written in the MRCP stuff. Okay, there. Patients Afro-Caribbean origin. ACE inhibitors, if it is not effective, you use calcium channel blockers or thiazide diuretic. Calcium channel blocker or thiazide diuretic. take your ACE inhibitors or ARB out altogether and just proceed with the what's next. Your calcium channel blocker and thiazide diuretic, furosemide and torsemide. Should I show it to you, or was it, I don't have, or was it already clear?
I got it already. No
Okay.
issue.
Can you repeat that again?
Here, let me highlight it. Maybe I can highlight it. In Afro-Caribbean group of patients, if your ACE inhibitors and your ARB, as Tiopo pointed out just now, that there is somewhat a pattern for ACE inhibitor or your ARB, both RAS blockers basically. When I'll just use RAS blockers, when I say RAS blockers, it includes your ACE inhibitors and ARB. There's a pattern that ACE inhibitors and ARB, they don't work. So what do we give? We give calcium channel blockers or thiazide diuretics, which are also your first line. Just proceed to what's next. See here, written. Calcium channel blockers or thiazide diuretics in Afro-Caribbean origin. Okay. Any other questions? Can we move on?
Oh, I have another question on that one. Meaning, since the ACE and ARB are contraindicated in pregnancy, and they have to be given with cautions in the childbearing potentials. Meaning, for the childbearing patient, I can also give CCB and the thiazide instead.
Yes.
Okay.
Yes. But thiazide, you have to be careful, or not, or exclude it entirely. I'll talk about hypertension and pregnancy soon. Okay, we'll get to that. So let's talk about diabetes for a while. Diabetes and hypertension, and we understand that when you know that patient is diabetic, automatically the risk group is already between 3 and 4. Between 3 and 4. If the patient shows signs of diabetic nephropathy, for example, it's immediately the 4th group, the highest risk group. So how do we treat patient with diabetes mellitus, which happens a lot of time? First point that we need to remember is our target BP. Our target BP we talked about earlier on is 120/80, right? Or an okay target is less than 140/80. 140, yeah, less than 140/90, sorry, not 80. But if there is if there is any form of end organ damage, even one, your BP target gets lowered. It becomes less than 130/80. Previously it was 140/90, now 130/80. That's the first point that we need to remember when it comes to BP, when it comes to hypertension in DM. Second, your ACE inhibitor is still considered your first line of drug. First line. And otherwise, other drugs, they follow the guideline as per use in the respective hospital. But ACE inhibitors is still considered your first line, just like what we talked about, just step by step just now. Third point, I've talked about this. We need to avoid the routine use of beta blockers. This is a new point in new guideline. Routine use of beta blockers must be avoided, even in uncomplicated case of hypertension in diabetes mellitus patients, especially with the use of diuretics with thiazides. Avoid beta blockers. It can cause insulin resistance. It can cause impairment of insulin secretion. it can alter the response to the autonomic response to hypoglycemia. It means that if there's too less, if your glucose level becomes too less, the autonomic nervous system may not be able to respond appropriately to that just from the usage of beta blockers being used together with diuretics as well. I was thinking of another word, but okay, let's just use being used together with diuretics. So in total, in summary, avoid beta blockers. Okay, next. Hypertension and pregnancy. Hypertension and pregnancy. When we talk about hypertension and pregnancy, a lot of people, a lot of students assume that when it comes to hypertension and pregnancy, the first thought that comes into their mind is preeclampsia and eclampsia. And we're treating preeclampsia and eclampsia. But that's not the case. When it comes to hypertension in pregnancy, there are so many different spectrums of that, which I'm going to point out. What are the spectrums of hypertension in pregnancy? Number one, pre-existing hypertension. Even before the pregnancy, the patient is already diagnosed with hypertension. That's the first form of hypertension during pregnancy. Pre-existing hypertension. Second, gestational hypertension. Gestational hypertension, or also known as pregnancy-induced hypertension. It is, from the name itself, you understand that patient did not have any history of hypertension, but because of the pregnancy, the patient suddenly has hypertension. And it is only diagnosed as gestational hypertension or pregnancy-induced hypertension when the fetus is at least 20 weeks of gestation. The gestational age of the fetus is 20 weeks. If less than that, it's not gestational hypertension. And there is a normalization of BP 6 weeks postpartum, 6 weeks after delivery. Notice that the BP decreases. So that's what your gestational hypertension means. Next, of course, will be your preeclampsia. Number 3, preeclampsia. We're not going to go deep into what's preeclampsia, eclampsia, and how to manage, how to diagnose all of this, because it's already obstetrics. If you are interested, you can read more on it, and we can talk about it maybe some other time, or you can you can ask me when you meet me, or you can chat in the group, sure. But we're not going to go deep into preeclampsia and eclampsia. That's number 3, right? Preeclampsia. Number 4, eclampsia. Number 5, preeclampsia superimposed on chronic hypertension. Or in other words, preeclampsia superimposed on pre-existing hypertension, like the first point, pre-existing hypertension, chronic hypertension. Next, pre-existing hypertension superimposed by gestational hypertension and proteinuria. That's the 6th one. It is not eclampsia yet. It is not preeclampsia yet. It's just hypertension, gestational hypertension plus proteinuria, still not preeclampsia. because your preeclampsia and eclampsia, there are specific levels of your protein in the urine for you to diagnose eclampsia and preeclampsia. So between your normal and that cut point for eclampsia, preeclampsia, that is where this form of hypertension during pregnancy falls under. Last but not least, your antenatally unclassified hypertension. Antenatally unclassified hypertension. This is when you can't really know, you can't really pinpoint which one it is. Maybe less than 20 weeks gestation, a little bit of proteinuria, and a little bit of here and there, a mix of all these criteria, and it's difficult to pinpoint what it is. So the conclusion is antenatally unclassified hypertension. So drugs to use in these conditions. This, by the way, this condition, it's not from a textbook, it's from a guide, from the guideline itself. So it's legit. Treatment, drugs. I'm not going to like specify each and every part of this because it will be a very long talk. But generally, number one is to give methyl dopa, drugs that are safe to use during pregnancy, antihypertensive drug. First, number one, methyl dopa. Number two, your beta blockers, but we can't give all beta blockers. We can't give all beta blockers. Labetalol is commonly used. Labetalol. Talking about labetalol, this our pharmacology book lecture material. If you open antihypertensive drug, it says that labetalol is contraindicated in pregnancy. I was shocked. I don't know why it's here. It says it's contraindicated. It says that it's bad, but all the guidelines, official guidelines that I've checked in European guideline, American guideline, even our Malaysian guideline, labetalol is one of the first line of drugs used in preeclampsia, eclampsia, or pregnancy-induced hypertension. So whether this is right or wrong, I don't know. So I just want to point out that something is fishy in this lecture material, especially on that point. Okay. Atenolol is best avoided. Beta blocker, atenolol. Nitrates, your nitroglycerin, they are only used in case of pulmonary edema. Drugs that are before going to contraindicated, the next line of drug that is okay to use in pregnancy are your CCB, your calcium channel blockers. Another drug that you can use as an alternative if you can't use labetalol or any other beta blockers, you can use hydralazine IV together with labetalol IV. Labetalol is also given IV. Another drug that is commonly used in pregnancy for hypertension is your magnesium sulfate. It is considered as an anticonvulsant in pregnancy-induced hypertension or hypertension in pregnancy. Used as a treatment or prophylaxis altogether. Commonly used in preeclampsia and eclampsia. Can anybody, I've talked about this, can anybody tell me in what situation do we use magnesium sulfate also? Let me give you a clue. It is a form of arrhythmia.
I think something points, something they point.
Torsade de point. T-O-R, torsade de point. Torsade de point. It is commonly used because torsade de point is caused by hypomagnesemia. So we give magnesium sulfate. So these are the two main instances where magnesium sulfate is used. Number one is in your torsade de point. Second is your convulsions during eclampsia or preeclampsia, or just to prevent convulsion for hypertension during pregnancy. Drugs that are not safe to use during pregnancy are your ACE inhibitors, your ARB, your diuretics. You know, diuretics, it flushes out a lot of fluid from your body, right? So there's a risk for oligohydramnios for the fetus. It means that there's not enough for, maybe Nifia does not know what oligohydramnios means. It means that there's not enough amniotic fluid. There's very little amniotic pockets for the baby. So diuretics, especially thiazide, it can cause oligohydramnios very quickly. Another one, your direct renin inhibitor, your new drug that we talked about just now, your aliskiren, is also contraindicated during pregnancy. Okay, so far so good. Not too much. Yeah.
I just want to be sure that we're on the same page. Can you repeat them again? The contraindicated drugs.
ACE inhibitors, ARB, diuretics, all diuretics, and your direct renin inhibitors.
Okay, thank you. Just wanted to be sure.
All right. I hope everybody is okay. Not too much information yet. We are still on hypertension, and a few points that I still want to cover. I hope it's interesting so far. So if you don't have any more questions, let me just move on to the next point that I want to talk about. Let's see if I missed out any other point. No, no. Okay. Next point I want to talk about something very interesting. I hope you are as excited as I was when I first learned about it. There's this phenomenon called white coat hypertension. Maybe you've heard of it, or maybe you've not. White coat.
Yes.
White coat, yeah, hypertension. White coat hypertension. Interesting phenomenon. When I first heard it, I thought it was just like, you know, a funny thing and not serious. I discovered it was serious when it was actually included in the guideline, the European Cardiology Society guideline for hypertension. So for people who don't know what white coat hypertension is, it is an elevation of BP in the office, and once the patient is out of the office, the BP normalizes. Elevated office BP despite normal out of office BP means just being in the office elevates the BP. I don't know for what stress and what not, I don't know. So this is what they call white coat hypertension. Another phenomenon that is also, I've heard it before, I did not think it was a serious thing. And when I look into the guideline, it was also in the guideline. It's called mask hypertension. Mask hypertension. This is upside down. In the office, normal BP. Outside of office, elevated BP. See, being in the office, some people, they feel stressed out being in the office. They not just stressed out, maybe some other factors in the office. And some people, when they are in the office, they feel calm. They're not stressed out. Their BP is not high. But when they are out of the office, suddenly their BP increases. I don't know, maybe there are some other outside of office factors, family factors, and stuff like that. So this is what they call mask hypertension, white coat and mask hypertension. Treatment for this. Apparently, treatment is still understudied. You can still follow your step-by-step algorithm like we talked about earlier on. But they're still studying these two phenomena, and hopefully they'll find a better treatment plan for patients with white coat and mask hypertension. Okay. Now, before we move on to the next point, if we are not already tired, I want to talk last point on hypertension is a phenomenon that I think most of us are already familiar with. It's called isolated systolic hypertension. It's when your systolic BP increases, your diastolic BP decreases. Isolated. So it was shown that isolated BP it occurs mostly in the elderly patients, or occurs in the older age, and only about less than 10% of adults between 40 and 60, but most of them, they are elderly patients. So how do you treat isolated systolic hypertension? Your first line of drug is your thiazide diuretic instead of your ACE inhibitors and your ARB. Your thiazide diuretics becomes your first. Then the rest follows the step-by-step guideline that we talked about earlier on. So this is the difference between the treatment. Okay, so that's hypertension. Everybody okay? Questions? It's 8:30. We started at 7:15 just now. We have about 15 more minutes, 15-20 minutes. Would you guys like to would you like to move on to the next thing in mind that I have planned out, or we're okay with hypertension only today?
With the 15 minutes, you can just round up the class.
Okay, run up.
No, you said 15 minutes that you still have something you'd have loved to say now.
I do, but this is no longer on hypertension. It's no longer on hypertension. Ivy wanted to say something?
Introduction.
Okay. All right. I'm done with hypertension. I want to talk next is on heart failure. Heart failure is another interesting topic to talk about. Okay, anyway.
You want to give the introduction, or you want to finish the heart failure again?
Finish?
I mean, do you want to give introduction on heart failure, or this is a different topic?
I can start.
How far can you go?
How far can I go? I don't know.
I mean, what do you have in mind? Now, that's what I'm saying. Is it that
what I have in mind? I already planned out everything till the end of heart failure. So whenever time is up, I'll stop wherever it is. Is that okay?
Okay.
Okay.
Very okay.
All right. So heart failure, another very interesting topic to talk about. Now, heart failure, and I want you to take note that I don't say congestive heart failure too, because congestive heart failure, it's a different it has a different meaning. So I'm just going to use an umbrella term, that is heart failure. First point that I want us to understand is that heart failure is not a disease. It's not a diagnosis. Shock, right? It is not a diagnosis. It is a syndrome of an actual problem, of the first primary problem. It is most often a complication of an actual problem. So if you see a patient, something happens with a patient and you suspect that the patient maybe has acute heart failure, but that should not be your number one thing, the first thing that you should write when you write your diagnosis. Your diagnosis should be the actual thing that's causing your heart failure. A lot of things can cause heart failure. A lot of things can cause heart failure, even from genetics up to trauma can cause heart failure. That is why it is not the primary diagnosis. But anyway, what is heart failure? Again, as I said just now, it is a syndrome, right? It is a syndrome associated with dysfunction of your systolic and diastolic dysfunction, associated with structural and functional abnormalities of the heart, and also associated with neurohumoral and vasoconstriction imbalance. These four things. First, structural and functional abnormalities of the heart. Second, systolic and or diastolic dysfunction of the heart. And I'm sorry, not four, three, and four. Neurohormonal and vasoconstriction imbalance. Okay. So generally, according to the clinical guidelines, they are divided into your systolic and diastolic problems for heart failure. But what we learn in propaedutics or therapy is a bunch of other things going on. So let me just read out what we've commonly have heard from propaedutics and therapy. In this subject, we classify them into acute or chronic heart failure, left or right-sided heart failure, or both biventricular heart failure. And biventricular heart failure is what people use to refer as congestive heart failure. Whenever they say congestive heart failure, it's both sides, not one side. Next will be systolic or diastolic dysfunction, like I said earlier on. Next will be backward or forward failure. Forward means that the problem is on your cardiac output going out. Backward is when there is an increase of venous return going back. Instead of going out, the blood is going into the heart, is going back, flowing back. That's also a form of heart failure. It's not very common, but well, that's what's written in our material. Next would be low output and high systemic resistance. Means low cardiac output plus a high systemic resistance. Then next would be your high output but low vascular resistance. Then next would be your classification based on bodies, your government associations. Your American Heart Association, your NIHA, your New York Heart Association, your KILIP classification, and your Strajeska-Vasilyenko classification, which is mostly used in Russia anyway. Based on the guidelines, they use systolic and diastolic dysfunction, your NIHA classification, your New York Heart Association classification most often. The rest is just I think it's just for knowledge sake. But for practicality, these are the two main ones that people use. Now, another point that some students might find it confusing is when to use your American Heart Association classification, your NIHA, your New York Heart Association classification, KILIP, and your Sturgis-Kovasilenko classification. It depends on whether that patient is having acute or chronic heart failure. You know that in chronic heart failure, mostly affects the lungs, pulmonary hypertension, your pulmonary edema, while your chronic heart failure mostly you see pedal edema, your edema on extremities. So based on this understanding, you go back to why to how this associations classify heart failure. KILIP, for example, KILIP 1, 2, 3, 4 is based on it is based on the classification is based on pulmonary congestion. It means the pulmonary edema. So understanding that it is based on pulmonary edema, it means your KILIP classification is more towards acute heart failure. So if the patient, for example, has MI, acute transmural MI, what wall, then complicated by acute heart failure, then KILIP what? So that is why KILIP is most often used in acute heart failure. The rest is based on not just congestion in pulmonary circulation, but also your systemic circulation. So in other words, the rest can be used in chronic heart failure. Chronic heart failure. Okay. Next point that I want to talk about, still under classification, is degree of compensation. Degree of compensation. It can be compensated, subcompensated, or decompensated. Now I want to talk about compensation first. How does the body react to compensate these changes in the heart? There are two main mechanisms how the body can compensate. Number one is your Frank-Starling mechanism. Your Frank-Starling mechanism, or Frank-Starling law. It says that your stroke volume, the stroke volume of your left ventricle will increase as the left ventricular volume also increases. Stroke volume, what does that mean? It means the ability of the heart to contract and push out all the blood. So this law simply means that when there is more blood, as the volume of blood increases in the left ventricle, the stronger the heart will contract. Because the cardiomyocyte will stretch very much, then it will forcefully push the blood out. That is Frank-Starling mechanism way to compensate. Second way to compensate is through your BP, and that is through your systemic vasoconstriction, so as to increase your BP. Now understand that during heart failure, your BP will start from low. Patient with heart failure will start from hypotension. We need to understand this first. And this is very important, especially when we talk about treatment later on, because some of the treatment would include your ACE inhibitors. and your beta blockers. But you have to be careful with that. No, not beta blockers. Your ACE inhibitors, not beta blockers are contraindicated. Remember, ACE inhibitors, and how to the dose for ACE inhibitors. You cannot give full dose for ACE inhibitors because the phenomenon of heart failure begins from hypertension. If you give ACE inhibitor for patient with hypertension, the patient will just collapse. So we have to be careful with that. We'll talk about that as we talk about the treatment of heart failure. So that, as I mentioned earlier on, these are the two ways the body compensates: Frank Starling law and your systemic vasoconstriction. And all of this happens during initial stage of the heart failure. The patient will be able to compensate, will be able to compensate, and then as it becomes too much, it becomes subcompensated, and until there's excessive stimulation, then the body cannot compensate anymore. So it becomes decompensated or disadapted, if that's even a word. So what happens when the body cannot adapt to it anymore or cannot compensate anymore? Your end organ damage will happen. Includes your left ventricular hypertension, increase in heart rate, increase in oxygen demand, and decrease in perfusion. There's increase in oxygen demand and decrease in perfusion. Risk for arrhythmias, even the so-called fatal arrhythmias that we talked about, your VTAC, ventricular tachycardia, and your VFib, your ventricular fibrillation. So this can happen during heart failure, especially during the decompensative stage. Okay. It's 8:46 already, so our 1.5 hour is done. Next class we'll talk more on heart failure and how to treat heart failure, what is the first line of drug, how to dose the drugs based on our understanding of the pathogenesis of all of this. And yeah, hopefully we'll be able to finish everything next week and move on to something that is not related to beta blocker, ACE inhibitors and stuff like that, because when we talk about all of this, it's almost the same thing. Okay, any questions so far?
Thank you for sacrificing your time.
You're welcome.
Thank you very much.
You're welcome.
So going so.
Thank you. Thank you.
Thank you so much.
You're welcome.
Good night,
You're welcome.
everybody.
All right.
That's be done, yeah.
Good night.
Good night.
Bye bye.
Bye bye.